Hello, my name's Julia Platts. I'm a consultant in Cardiff and Vale and National Clinical Lead for Diabetes in Wales, and I'm going to talk today about hybrid closed loops in type 1 diabetes for primary care. We've known for a long time that insulin injections have limitations. Basal insulin requirements aren't the same over 24 hours. We usually give long-acting insulin for this, but the requirements vary from day to day depending on exercise, emotion, health, menstrual cycle, and lots of other factors. And rapid insulin requirements vary with food, exercise, how much insulin is on board. So insulin pumps were developed to reduce hyperglycemia, reduce hypoglycemia, and to improve quality of life. The insulin pump is a device which gives rapid-acting insulin continuously, and that replaces the long-acting insulin. And then people give extra doses of insulin through the pump to match food, replacing the short-acting insulin. In a hybrid closed loop, the insulin delivery is controlled by the continuous glucose monitor result via an algorithm. A target glucose level is set, for example, 5.5 or 6.1, and tiny microboluses are given every 5 minutes to achieve this level of glucose. And the reason they're hybrid is that the person still needs to carbohydrate count and bolus via the pump for food. Fully closed loops are in development and are probably going to be with us in a couple of years. So hybrid closed loops have manual modes and have an automatic mode, and generally work much better in automatic mode. So we try and keep them in automatic mode as much as possible. If the sensor fails or there's no sensor, then they'll run in manual mode. We set targets, insulin to carbohydrate ratios, insulin sensitivity factor, which is how much 1 unit of insulin will lower the glucose, and active insulin time. We can use different targets, for example, for exercise or for illness. These pumps are extremely good at keeping the glucose on target overnight and when people aren't eating, and generally have a huge impact on mental well-being. These are the hybrid closed loops that are currently available: the Medtronic, the t:slim, the Omnipod 5, and the Cambridge APS systems. In December 2023, NICE issued a technology appraisal which recommended hybrid closed loops are used in the following groups: in children and young people, in people who are pregnant or planning pregnancy, and people with type 1 diabetes whose HbA1c is above 58 millimoles per mole despite good care. In Wales, that probably equates to about 11,000 people. Currently, we've got about 8 to 23% of people on pumps in Wales, and probably about 50% of children. So we're going to increasingly see these pumps in all walks of life. How do hybrid closed loops impact primary care? Well, people will get their education, the planning of the pump starts and the follow-up in secondary care. And most of the equipment will be provided directly from primary care. There is a caveat. Some of the pumps are now starting to use Freestyle Libre 2 Plus and Freestyle Libre 3 as their glucose monitoring system, and these can be prescribed in primary care. Patients will need 10 ml vials of insulin on prescription. This will be short-acting insulin, but some systems use the ultra-short-acting insulin, such as Fiasp. People will always require glucose testing strips and ketone strips, despite the continuous glucose monitoring, because sometimes the continuous glucose monitoring systems fail, sometimes they're inaccurate, and sometimes we're not sure. And in those situations, we have to revert to capillary monitoring. People on pumps also need backup insulin pens, and this is because the pumps may break down, or they may get a high reading on the pump, meaning that there's some kind of problem with the system. And at those points, they'll revert to their backup insulin pens. These will only need to be occasional prescriptions to make sure they're in date, and they'll be both short-acting insulin, such as Novorapid or Fiasp, and long-acting insulin, such as Humulin I or Levemir. If somebody presents with hyperglycemia, what should we do? Hyperglycemia on these hybrid closed loops usually responds within 2 hours, and if it stays unchanged after 2 hours, it often suggests there's a problem with the system, with the cannula, with the tubing, with the insulin, with the pump, or that the patient's ill. People at that point should revert to giving a correction via their insulin pen, and they should redraw up and reapply their pump using fresh insulin and a fresh system. But it should always remember that DKA happens very quickly with pump systems because there's no background insulin on board. So patients must know what to do if the glucose goes high. They must know to test for ketones at lower glucoses. And if they have got ketones that they can't clear, present early for treatment. Generally speaking, hypoglycemia needs less glucose to treat, such as 1 or 2 jelly babies, because these pumps have already switched off the insulin delivery as the glucose has dropped. If there are any people out there on insulin pumps that have been lost to follow up or disengaged, then please refer those people back to secondary care so that they can be kept updated with developments and the latest updates. Most people who are on pumps will have their annual review in primary care, although many of the 8 care processes will be done in secondary care, such as HbA1c, blood pressure, BMI, and others. Travel letters and other supportive information can all be obtained from secondary care. We find about 1/4 to 1/3 of people with type 1 diabetes don't attend secondary care. And this is most likely to be people in the most deprived groups, people from ethnic minority backgrounds, and the elderly. And these are also the same group of people who have a lower pump use. We're trying to close this inequality gap. So anybody who would like to consider technology or a pump, please re-refer to secondary care. We don't consider literacy levels or different languages to be a barrier. We can overcome these. And we're also working on solutions for those people who may not have access to smartphones.